remains property of the patient and normally stay at low levels. Thank you very much. So if anybody wants to ask one question, we can take one, since I was a bit slow. Any question, anybody?
One question?
Yes.
Jonne Dora from the Netherlands. I have one question about how you use the esophageal pressure swings and the transpulmonary pressure as a measure of work of breathing. But what you say when you increase your EDI or NAVA level, you give more support. And the big difference is when we do our normal respiration, we get a negative pressure, so a negative pressure swing. If we give positive pressure, well, you have less pressure swing. So how can you discriminate between the work of breathing of the patient and the work of breathing of the ventilator? So
with positive pressure ventilation, you would get that situation that you actually get, you cancel out the pressure of the patient, correct? If you would use negative pressure ventilation, you would actually take over the patient's work and it wouldn't show the same way. But the pressure you apply here is how do you say, you are canceling the patient's pressure technically. I mean, you are giving a pressure before the patient is doing it. And he can rely upon there is a pressure coming, therefore he reduces his effort, which means that his own effort and the esophageal pressure swing goes down due to that. That's how you unload with the positive pressure ventilation.
You can't measure the swing down from the patient because you give positive.
Well, I mean, you can have, we've used like in several studies like the ratio of the esophageal to transpulmonary pressure, which is like telling what the relative contribution of the patient and the ventilator is. That's a good measure to do it. So you can, then you get the scale from 1 to 0, that you can tell what the relative contribution of the machine versus the patient would be. But you have to measure both the esophageal pressure and the ventilator pressure.
And Ring is going to present a new index. Is there going to be a PVPC presentation?
No. There is another question, I think.
Thank you. I'm Dr. Lucian from China. My question is, when you're doing the titration of setting the NAVA level, you use the pantone of, I think it's air pressure, for the setting the NAVA level. But my question is, why do you think the plateau pressure, I mean the plateau air pressure, it's good for the patient? For example, if you do a titration on me, I'm a healthy subject, you will find the plateau too, but I don't need a mechanical ventilation and I don't need a unhealthy subject, but also get a plateau air pressure. Thank you.
It's what you say is a very good question, and as I'm saying, I mean, we all asked ourselves that question a million times. And what I try to say in this lecture is that the pressure that you see, that when the plateau on the machine, if you look at tidal volume or if you look at the actual pressure, and I mean, sometimes it's not so clear, sometimes it's more clear, sometimes it's like very clear, like where that plateau is. To say like, what you do here is that you are actually coming to a point where the patient's down-regulation of drive goes so fast that he is simply saying that I don't want to have more. So if you come up to that plateau and you see it clearly, I mean, in that situation, I would say that the patient is telling you that, I mean, you have given me enough, anything more you do, give me, I will reduce my drive. Now, if you prefer to have the patient breathing at 25% of his, say, if you have him on a spontaneous breathing trial and you take him back on the ventilator, you want to suppress him to 25% of the diaphragm activity he had there, or if you prefer to be at 50%. That's, I think, is a physiology issue about how much can we assist the patient, how prepared, like in what phase is he, should he get a lot of unloading, should he not, what is the underlying disease. I think the point here is to say that the patient chooses the volumes, and you have to make sure that you have given him enough assist to be supported to the volumes that he should be. If the volumes goes up over that, I would say that then you have some CO2 problem in the background, and metabolic acidosis, could be anything. But in that case, it doesn't help that you increase the assist, because the patient just wants more and more volume, because he has to get ventilation to happen in the way that he wants. And if the lungs are very small because of an ARDS, so that the part of the lungs that are ventilated, the alveolar ventilation is very impaired, then if you increase the volume, you must increase the volume to just stay alive, and they do that. We see that in the animals very, very, very clearly. I think Jukka Takala had a question.
Takala, Switzerland. I think what we are a little bit isolating here is a problem which is part of a very complex issue of pathophysiologic disturbances in the critical ill patient. I mean, we have numerous issues which are interfering with the normal control of breathing. So it is a completely different issue if we regulate or match the drive of the patient in a one who has a normal control of breathing. However, in our ICU patients, we have, especially over a longer period of time, we have multiple factors which are likely to make the drive and the control abnormal, such as preceding acidosis in the CNS, for example, such as abnormalities in the drive because of, say, the drugs we are giving the patients, abnormalities due to essential changes, for example, because of delirium. And in those cases, I think it's important to differentiate whether we are just matching the ventilatory needs or the actual needs of the patient at that moment in a pathologic situation, or should we first try to normalize the conditions where we let the patient take over the control of breathing?
Well, to say, I think it's exactly what you described here is like a summary of all the experiments I just showed you. It's like you can create a situation where the ventilator can be taken over by the patient. The problem is, when can he not? And I think that my 2 points here again is that the thing is not so much to strive after the tidal volume, because the tidal volume is, we say 6 ml per kilo today, but I think I show you an example that shows that it means nothing. It's a low tidal volume is all it is. At some point you might have to apply, as Christian Karadenides will talk about, ECMO in order to remove the CO2. If you don't do that, well, in that situation you will have to go to like a controlled mode of ventilation, sedate the patient, and go with the permissive hypercapnia. But somehow, if you want to protect those lungs, they cannot be ventilated with high volumes. But I think that what you see when you look upon the diaphragm activity, when you do the titration, and that's why I wouldn't say it's the titration itself, but when you increase the assist with NAVA, if you don't see the drive go down, well, that's a warning sign, a big one. If the patient keeps his drive and pressures just increase and volume increases, that's a warning sign. That's something that says that there's something more to this patient than just load of breathing. It's a much more complicated situation. And I think that's, the point more than anything is to watch out for. So I think we go for coffee now. No one, Lucas, comment? Okay.
Thank you very much. Lucas Brenner from Switzerland. I just wanted to come back to the question asked by a colleague from China before about the titration procedure in healthy subjects. We actually never did it, so I don't know if anybody else did a titration procedure in healthy subjects, so I wouldn't be so sure about if you get the same response as in a patient, because what we think is, like, the first response when the patient actually increases his tidal volume and pressure, that will reflect taking away the additional load. So if you do a titration in a healthy subject, you would need an interface which puts a load on you, and whenever you get the same response, I would assume that the response is related to the load you impose on the healthy subject. But I would be very surprised if you get the same response in a healthy subject as in a loaded patient?
No, you don't get the same response. But we did, and we published it, and I don't know if you even were a co-author on the paper. We did a study in healthy subjects where we went from a 0 NAVA level and with no load, and we just increased the NAVA level till we had eliminated all the esophageal pressure so that we were completely unloaded. And we could not eliminate the diaphragm activity, and that was the number one, and we could not increase the tidal volume. So although there was no plateau, because we did not increase the tidal volume, because we just got more pressure and down-regulated, because in order to reach the plateau, you have to go up in order to come to the point where you're satisfied. You have to be below satisfaction point. That's like where you get the increase in pressure. Otherwise, I would just say, I don't want to increase my transpulmonary pressure because I'm good where I am. If you are in failure, you're breathing with a tidal volume that is lower than the one you get with the ventilator. So the first thing you want to do is restore tidal volume. Once you have come there, then you stay there. So this is where it's kind of, so coffee?